I'm talking today on antifibrinolytics in major orthopedic surgery. So I'm going to talk about what are antifibrinolytics, their mechanism, their effects in trauma, their effects in elective surgery such as total hip, total knee, arthroplasty, and in spinal surgery. There are three major types of antifibrinolytics. There's aminocaproic acid, a protein, and then tranexamic acid. The aminocaproic acid and a protein aren't available in Australia, and in fact, the protein is no longer used due to its renal impairment, cause of renal impairment. And tranexamic acid, so the only one available in Australia, and it's the one that has the most research on. So we'll talk mainly about tranexamic acid today. Alright, so antifibrinolytics, what do? They reduce perioperative blood loss, they reduce the requirement for transfusions, and they reduce total costs. They're most studied in cardiac surgery and are now routinely used in cardiac surgery, both intraoperatively and postoperatively. There's now a considerable body of evidence for their use in major orthopedic surgery, such as trauma surgery, arthroplasty, and in spinal surgery. So just a quick revision of your coagulation cascade. So initially you get an injury to the vessel, so be that out on the road or be that under the surgeon's knife on the table, and the injury to the vessel causes the exposure of the endothelium, and so platelets which are passing by become activated and aggregate at the site of exposure. The platelets, whilst becoming activated, reduce multiple factors, including von Willebrand's factor, which is released by both the platelets and the endothelium. That causes increased aggregation of the platelets. Also other things such as platelet aggregating factor, platelet factor 4, serotonin, and multiple other factors are released, which then increase the chemotaxis, or the platelets who come to the area, as well as increase their stickiness. The platelets also change shape from an ovoid shape to a stellate shape, so that they can interlock better and form a better plug. We then get into the intrinsic and extrinsic pathway, which you've probably seen before, and basically the intrinsic system is initiated by the endothelial factors, which are in direct contact with the factors. So, and then you get an inactive zymogen going to an active form, and you get this cascade going down. That's the intrinsic pathway. The extrinsic pathway is activated by the tissue factors, which are produced by the platelets and by the endothelium. And so they all lead to the common pathway down here, where factor 10 is activated to 10A, which then changes prothrombin to thrombin. Thrombin's probably the key here. That's the one that upregulates and downregulates the whole cycle. It then changes fibrinogen to fibrin. And so fibrin initially is in a monomer form, and that monomer form is then basically covalently bonded to a polymer form, which is a strong, rigid clot, with the help of factor 13. So you have a strong clot there, and this clot will just increase in size unless we started to break down some of the fibrin. And that's done with the tissue-type plasminogen activator, TPA. When it binds with plasminogen, it forms plasmin, and then it binds to the fibrin itself, and it causes the fibrin to break down, and you get the degradation products. And these degradation products can be measured, for example, with a D dimer. So when you're measuring D dimers, that's what you're measuring. So mechanisms of action of the tranexamic acid. So it increases fibrinolysis. So it inhibits a clot degradation. Okay, and it's a reversible interaction with plasminogen. It binds to the lysine binding sites of the plasminogen, which inhibits its ability to then bind to fibrin. Okay, and it's in its maximum concentration about 3 hours. It's excreted in urine, and as I said before, D dimers can be measured to see its effect, and it's 10 times more potent than aminocaproic acid. So having a quick look here, this is the tissue plasminogen activator. When it binds to plasmin, it then binds to the fibrin, and then causes the fibrin to be degraded. When tranexamic acid comes in, it actually blocks here in this lysine receptor. So then the TPA can bind to a plasminogen and form plasmin, but can no longer bind to the fibrin. And so the fibrin then is not broken down. You still have this covalently bonded polymer of fibrin to maintain the clot and keep hemostasis. So just in regards to orthopaedic surgery, so major orthopaedic surgery puts a patient obviously at increased risk of bleeding. So it depends on the extent of the surgery. So for example, a revision hip or knee versus a primary hip or knee, patient's medical conditions, are they on antiplatelet therapy such as aspirin? And some of the things that are used to help with this are controlled hypotension, blood salvage systems such as cell saver, hemodilution and transfusions. And so antifibrinolytics, as we said, reduce the bleeding through an inhibition of the clot degradation. In total knee and total hip, up to 50% of patients require a transfusion at some stage, and the average amount is 2 units. Okay, total knees can have up to 1.5 litres lost, and with a hidden amount of 700 mils. Now, blood transfusions are not risk-free, and I think we sometimes forget that blood is actually a drug and it has considerable risks. In fact, the risk is so severe with immunomodulation, we know that all-cause mortality from someone receiving 1 unit of blood is increased significantly compared to those who don't receive blood. And so, in fact, it's so severe now that the American College of Physicians and the American College of Cardiologists have recommended that you don't give blood unless someone's actively bleeding for a HB that's more than 7, and that's just because of the risk of all-cause mortality increasing. Plus, they're expensive and are time-consuming. So just a quick look, as I said, there's immunomodulation, which is a risk, but also other complications. You have the acute hemolytic reaction, anaphylaxis, which is up to 1 in 20,000. Fluid overload can be up to 1% of our patients. Also, you can get tralia or acute lung injury. And then there's the other infections such as HIV, Hep B, and there's ones that we still don't know enough about, the prions, CJD and things like that. So getting a transfusion in itself, although it may be required in some cases, is a non-desirable thing if we can avoid it. Let's look at the effect of or the use of antifibrinolytics in trauma. So in 2010, there was this very large trial called the CRASH-2 trial, and it's been published in the Lancet. So we know that trauma triggers clot breakdown and can pathologically cause hyperfibrinolysis. Okay, and so we also know that hemorrhage is the cause of 1/3 of all traumatic deaths, and in fact, it's probably greater than that because hemorrhage can also cause multi-organ dysfunction, which also leads to death. This CRASH-2 trial had 274 hospitals involved, so multi-centre, multi-country trial, over 20,000 patients, and they looked at giving tranexamic acid to patients who were at risk of hemorrhage or who were hemorrhaging. And the way they looked at that was they looked at the systemic blood pressure. If that was less than 90, if the heart rate was greater than 110, they'd give the tranexamic acid within the first 8 hours. They'd give a loading dose, and then they'd also give an infusion over 8 hours. And they significantly found that there was a decrease in all-cause mortality and also a decrease in dying from bleeding. So just quickly, it's hard to see here, but all-cause mortality was significantly decreased, so was bleeding. What they didn't find was that there was no increase in any vascular occlusions. And so this is one of the things that people talk about with these drugs, is the side effects of the potential vascular occlusion. And this large multi-centre trial on trauma found no difference. And when you have a look, so this hasn't probably projected that well, if you look at vascular occlusive events, there's no increase at all. No increase in myocardial infarctions, no increase in stroke, no increase in PE, and no increase in DVTs. The BMJ also analysed this data, and they went through and they looked at the risk of death at baseline. And what they did is they looked at the ISS scores, they also looked at the risk of bleeding at the time, and they went through and they found that a person who is at greater risk of dying at baseline, so once they get into that hospital door before anything's done, they had the greatest effect from the tranexamic acid to those who had the lower risk of dying. And that also holds for those who have risk of bleeding, dying from bleeding. Those who are at a greater risk of dying from bleeding have the greater benefit with tranexamic acid. And They also looked at the thromboembolic events, and they found that there was no increased risk in thromboembolic events. So from that data, it's very, very strong evidence that in trauma and multi-trauma, so things like pelvic fractures and things like that, where there's a high risk of bleeding, that tranexamic acid should be used, okay, and is now routinely used. What's the story for elective surgery, hips and knees? So with total hip arthroplasty, there's level 1 evidence, and there's been level 1 evidence for quite a few years now, and the level 1 evidence is relatively strong. Not so, doesn't have the power of these 20,000 people in the CRASH-2 trial, but there is still good level 1 evidence to show that we should use tranexamic acid in arthroplasty surgery. Just a few of the systematic reviews, I'll just quickly go through them. So in 2011, JBJS, we did a trial, did a systematic review and meta-analysis with 350 patients, and they found that there was a significant decrease in intraoperative blood loss, significant increase in post-operative decrease in post-operative blood loss, and obviously a significant decrease in mean blood loss. They also found a significant decrease in blood transfusions, and as we spoke about before, the importance of avoiding transfusions if possible. And they found no increase in DVTs, PEs, or any thromboembolic events, and also no change in infection rates. This was also seen in 2009 in another meta-analysis which showed similar results. A significant decrease in loss of blood, significant decrease in requirements of transfusion, and no increase in venous thromboembolism. In fact, they found it slightly lower. This also holds true for total knee replacements. So total knee replacements, in fact, the data is even stronger than for hip replacements. And there's been multiple reviews as well, systematic reviews and meta-analyses. For example, Estrida in JBJS 2011 and Yang in 2011 in knee surgical trauma. Those trials also found significant reduction in blood transfusion, significant reductions in blood loss, and no increase in DVTs or pulmonary embolism. So the story is quite strong. What about cost effectiveness? So there's not a lot of journals on this, not a lot of articles on this. In journals of surgery and research, one of the SEPA looked a little bit at that, didn't actually go into numbers, but they spoke a bit about blood donation, so people who need, who require transfusions. They found that cost effectiveness was considerable versus giving tranexamic acid. They also looked at using normovolemic hemodilution, and they found it not to be effective in orthopedic procedures. Cell saver, they found also that this was not cost benefit. They found the thing to be most cost benefit was tranexamic acid. Another study looking at both total hip and total knee, and this is a recent one in 2013, and that looked at 33 studies, a large trial with up to 2,000 patients in it, and once again strong evidence to show that there was a decrease in blood loss and a decrease in requirement for transfusion, and once again no increased incidence of DVTs. And their final remark was that tranexamic acid should be considered for routine use in knee and hip arthroplasty to decrease blood loss. And just a few of their forest graphs, you can see there's quite a clear decrease in blood loss in total knees, evident in total hip, not as strong, but once again evident. Transfusion rate decreased in knees, once again in hips. So the picture is quite clear. DVTs, no change, once again also in hips. So the data shows that it improves loss of blood, it improves the decreased requirement for transfusions, and has no increase in thromboembolic events. Looking now at dosing, just quickly going over dosing. So there's, in total hip replacements, the dosing that they use for this is based on a meta-analysis. We looked at 11 studies, okay, and it looked at about 550 odd patients. And with the dosing, unfortunately, the trials that are used, the dosing we use today is 60 milligrams per kilogram total. But in all the trials, that dose was actually never used. it was 10 to 15 milligrams or 20 to 30 milligrams were used as the dosing, but from this they were able to extrapolate that probably 60 milligrams per kilogram is the dose that is required. Total knees, they also looked at meta-analysis of 16 studies, and once again they looked at studies which used a tourniquet, and again no studies looked at the 60 milligrams per kilogram dose. Studies looked at 20 to 50 and over 100, but they looked at the mean dose range and they all ended up at about 60 milligrams per kilograms. So what is the dosing? So the dosing required for a total knee joint replacement is 15 milligrams per kilogram, which is given 30 minutes prior to release of the tourniquet. Then a repeat bolus is given at the 8-hour mark, and then at the 16-hour mark another repeat bolus is given. If the person still bleeds, then we look at giving another dose at 24 hours. This is the same for total hip replacements. 15 milligrams given just prior to skin incision, then another bolus at 8 hours, another one at 16 hours, and then a third one can be given if required. Also, there's been some talk about can we give intra-articular versus intravenous. So there's been a few trials which show intra-articular can and does reduce the risk of bleeding and reduce the risk of the requirements for blood transfusion. One of the studies by Manier in 2012 looked at its usefulness versus intravenous, and they looked at a control group. They also looked at a group which had one intraoperative dose. They looked at a group that had an intraoperative dose and one postoperative dose. They looked at a group that had a pre-op and an intra-op. They also looked at one who had the full follow-up, so had the pre-operative dose and then had the intraoperative dose and then had the two follow-up doses. And then they looked at the group that had the single application. And they found that the group that received the full dosages did best, had least transfusions, had least blood loss. They then found the next group was the one that had the intraoperative dose and then one post-op dose, and the group that received the local did third best. So it does work, but its effectiveness is much less than that of intravenous dosage. They also looked at the amount of transfusions, and once again, this is very similar. The transfusion rate was decreased if you gave it locally compared to the control, considerably decreased and significantly decreased, but once again, it was not as effective as if you gave it intravenously. So intravenous use of tranexamic acid is better than giving it locally to the joint. Now, some of the contraindications to the use of tranexamic acid. So it's a bit soft, this one, the history of thrombosis. So it's more anecdotal evidence rather than strong evidence to show you that giving tranexamic acid to someone who has a history of DVT, PE, or cerebral thrombosis. So what they do say, and MIMS and some of the other and the guidelines from Pfizer, they say that if you are going to give it, then you should have on hand anticoagulation. So it's more of a relative contraindication. A complete contraindication is someone who's got an active DVT, PE, or cerebral thrombosis. There's also talk about not giving it to people who have acquired colour vision disturbance, and that's because there's a likelihood that they have central retinal artery thrombosis and venous thrombosis, so the risk is worsening the vision. So not to give it there, and not to give it to those who have subarachnoid hemorrhage. And also, obviously, those who have a hypersensitivity to tranexamic acid. So the meta-analysis that looked at the dosing, they also found that there's probably an increased risk of about 12 in every 1,000 patients who get tranexamic acid, increased risk of getting DVT. But most of the other research has shown there is no difference at all. But this 12 in 1,000 they found was also not significant. Also, there's a dose reduction that's recommended for those in renal impairment. So looking at our website here, we do have a protocol for this. And our protocol is that we give this routinely to hip and knee joint, primary and revision cases. Okay? We don't give it to DHSs. We avoid giving to those with DVTs and PEs, okay, and those with seizures disorders. The evidence that's a little bit soft. And when should we give it? And so this follows the pathway which we've spoken about before. First dose prior to skin incision and to the release of tourniquet and total knees, then 8 hours after, and then another one at the 16-hour mark. And it's the 15 milligrams per kilograms given unless the patient has renal impairment. And then there's a guideline. So this is all on the OrthoFRACS website. So spine surgery. So we've seen that in trauma, there's a strong benefit of tranexamic acid. We've seen in joint arthroplasty that tranexamic acid is a benefit and should be used. In spinal surgery, the evidence is not as strong. There's not as many articles showing that there is benefit, and we definitely do not currently know what sort of dosages we need here. So there's also talking, when you read the articles, about the risk of bleeding in spinal surgery leading to things such as epidural hematomas, but there's no evidence to show that there is an increased risk in epidural hematomas from, or reduced risk of epidural hematoma from giving tranexamic acid. One of the recent studies in 2013 from Yang was a looked at 9 blinded RCTs. They looked at about just over 500 patients. Unfortunately, the doses ranged, enormous range of dose from 15 to 100 milligrams per kilogram. They did find, however, that there was a significant reduction in total blood loss and that there was a significant reduction in blood transfusion. They found no increase in venous thromboembolism, and just looking, you can see quite clearly on the forest plot. One of the strongest articles here is this one from Al-Watidi, which showed changes of up to 40 to 50% reduction in blood loss and in transfusion rate. You can see also here the transfusion rate is significantly decreased. So, in conclusion, when looking at tranexamic acid, it is an effective and a safe way to decrease blood loss and allergenic blood transfusion. As I said, there's great risk in blood transfusion and cost, and if that can be avoided, then it should be avoided. And it's been especially shown in trauma, but has good evidence to show that we should use it routinely in joint arthroplasty surgery. There's some further research which is required, obviously, in the spinal population, especially in regards to dosing.